Well, good afternoon, everybody. I'm delighted to welcome you to this workshop that we're running today from the Global Health Network and in partnership with the Malaria Consortium. We are absolutely delighted that we were completely overwhelmed by people wanting to attend this. We had over 800 people apply, and we've now reached our maximum people that we can take on this workshop, but we are also live streaming this, so we hope that everybody else can attend on live stream, but we're also going to record this and so have this version up online so everybody can see it later. So I'm Trudy Lang from the Global Health Network, and I'm going to introduce my colleagues in the Malaria Consortium in a second. Just to explain how we want to run this workshop, we will have some introductions from James and the team at the Malaria Consortium shortly, who will explain the landscape of their concerns around malaria and COVID-19. And then after they've given you their outline, we will open up the discussion to all of you online, because we very much want this to be a workshop, and we'd really like to elicit where people see research priorities, where the questions may lie in that we really should be tackling in the moment of opportunity to do research within this pandemic. Just some quick tips on how to manage this platform. If you look on the toolbar, you will see an opportunity to add a chat and add a comment in Q&A, and there's a button that says Q&A in the middle. Please, during our call, our conversation pieces, please write in here anything you'd like to say, and when we get to the workshop element of this, we can pass you the mic, and we hope to hear from as many of you as possible. So I don't want to take up much of this precious time now. I'm going to hand to James and the team, and then we'll come back to facilitate the discussion very shortly. So thanks everyone for joining, and I'm delighted to introduce the Malaria Consortium, who will take you through the rest of this workshop. Thank you very much.
Thank you very much, Trudy, and welcome all participants. Thank you for sparing your time to join us on this very important topic. It's unprecedented times, definitely, and my colleagues and I have been putting in quite a bit of thinking to understand what the landscape is, and we're going to share that information with you today, and hopefully to create an interactive discussion that allows the collaboration as well as the joined up thinking that's very necessary at this time to really help and contribute to the reduction of the devastation that this pandemic is having. Two of my colleagues will be presenting. Prudence Hamadi, who's our senior technical advisor, will talk about the potential clinical interactions between COVID-19 and malaria in different at-risk populations. I will then give a short presentation on the effects of the pandemic or the responses to the pandemic on health systems in the context of malaria control and elimination. My colleague Jane Edwina Chan, who's our senior research advisor, will then conclude with some research priorities and some relevant research questions that should then set the stage for all the conversation and debate that we can have. We'll do our best to stick to time so that we can have at least 30 minutes for discussions. I will now hand over to my colleague Prudence, who will be presenting.
Okay, if you put the presentation up, James, then it'll be good. Okay. So welcome everybody, and thank you for taking part in this important discussion, and I hope it will be a discussion. So we're looking at the clinical approaches that will be determined by the epidemiological factors. So we know that COVID is at different stages of its development across countries, and WHO has classified countries into 1, no cases, 2, sporadic cases, 3, clusters of cases, and 4, community transmission. And that malaria itself also has different transmission intensities, from high transmission, moderate transmission, low transmission, and pre-elimination settings. and the presence of non-falciparum species, especially relapsing infections of P. vivax and P. ovale, how does that affect the co-infection risk? So we're looking at what do we know about the people who are affected most by malaria and by COVID. The people most affected by COVID, as far as we know at the moment from the countries which have mainly been in higher income countries, are the older adults are most affected, and people who have risk factors of non-communicable diseases like hypertension and cardiac problems seem to be most affected by severe disease, as well as old age. We know that ACE2 receptors play the major role in the infection of COVID, and that therefore people with hypertension and diabetes can be especially affected. We know for malaria, in high transmission zones, children and pregnant women are the most affected. And we know in low transmission areas, pre-elimination settings, particularly in Asia, it's young men who go into the forested areas who are most affected due to the nature of the vectors that are slightly different in Asia and the behaviors of the population who work in the forests. We see that from South Korea and Italy, which are two different countries that kept a case fatality rate by age, we see that children are not very severely affected. Although we have some data from China that show that children under 1 are more likely to be severely affected than older children. We know that the epidemic curves have been very different in different countries, and we don't really know why that is. We know that in some countries in Asia, the epidemic spread very slowly, whereas in countries like Italy, France, and the UK, they've spread very quickly around the whole country. We know that the age distribution in the country, for example, Italy has a lot of older people with underlying health conditions, so the mortality rate was very high. So we don't always understand that the different social and economic factors in a country, as well as the age distribution, can affect the epidemiological curves. James? So just to look at some of the pathophysiology of malaria and COVID-19 and where they have differences, we know that the malaria parasite enters through a bite of the infected mosquito. It goes to the liver cells, which then it multiplies and bursts into the circulation and mainly enters the red blood cells. We know that vivax malaria can recur many times. We know that malaria parasites sequester in the major organs. They block the circulation, and that leads to tissue hypoxia and organ failure, increase in lactic acid and acute respiratory distress syndrome and septic shock. We know that hypoglycemia is a strong feature of malaria. We know that breakdown of the red blood cells can lead to acute severe anemia, which contributes to reduced capacity to transport oxygen and adds to the risk of tissue hypoxia. We know that overreaction of the pro-inflammatory response due to the sequestration of parasites in vital organs can lead to organ failure and septic shock. For the coronavirus, we know that that has a different mode of entry. It has to attach to the ACE2 receptors in epithelial cells, mainly in the nose, pharynx, and lungs, but it also can enter through the GI tract, and it travels to other organs such as the heart, liver, and kidneys. We know that destruction of the alveolar cells that have the ACE2 receptors can lead to less oxygen transfer and lead to pneumonia and acute respiratory distress syndrome. We know that COVID pneumonia can also produce anemia due to the pro-inflammatory response. And we know that the exaggerated pro-inflammatory response leads to exudation of fluids into the alveolar space, which reduces oxygen transfer and leads to ARDS, and eventually tissue hypoxia and shock. The virus can attack the epithelial cells throughout the body and damages the kidneys, heart, and blood vessels. And we know that the ACE2 receptors play a major role in hypertension and diabetes, and that's why they've contributed a lot to the mortality of COVID. So if we look at the presentation of the two diseases and the challenges at first contact. So if we look at uncomplicated malaria and the symptoms, both of Vivax and falciparum malaria, they consist of fever and general malaise, headache, body aches, etc. Simple malaria can be treated in the community. We've got a good biological test, we've got good treatment. We know that chloroquine plus primaquine is effective treatment for Vivax, except in areas where there's chloroquine resistance. We know that there are asymptomatic infections, particularly in low transmission areas, which have been a problem for malaria elimination. We know that asymptomatic infections can be infectious. We know, however, that the biological tests required for malaria do require close health worker patient contact. In COVID, it can present as asymptomatic or mild or severe. And we know that those presentations, the asymptomatic phase seems to be particularly problematic in the spread because people don't know they have it and yet they can still spread it. The difference between malaria and COVID for the presentation is that there's usually cough. About 60% of patients have a dry new cough when they present with a mild disease. We know that when there's a combination of the two with malaria and COVID, that you'll get cough, but also fast breathing, malaise, weakness, sore throat, and possibly diarrhea. So that the challenge is how to manage those patients that have a coexisting condition, particularly at community level. When we look at the severe manifestations of the disease, the differences are that severe malaria progresses very rapidly from first symptoms to severe disease. Whereas COVID, there's a long delay between the onset of symptoms and the onset of severe disease, often about 7 days when people first start getting ill to when they become in need of intensive care. We know that hypoglycemia is a big feature of severe malaria, as well as cerebral malaria, which involves loss of consciousness and convulsions. We also know that the same as in COVID, you can get acute respiratory distress syndrome, lactic acidosis, and septic shock. We know that also severe malaria and COVID can affect the kidney and the liver and result in multiple organ dysfunction. So when we're thinking about the treatment, we know that we've got good treatment for malaria if people can get access to it. But we know that they often require blood transfusion, and we don't know what the effect of blood transfusion would be in COVID, because the inflammatory reaction is slightly different. The cause of the inflammatory reaction is slightly different, and the outcome is slightly different. So we need to make sure that if we give blood transfusion, will that be good or will that be a danger? We know that it's highly infectious to other people, so that you need to isolate the patients. And if you have malaria and COVID together on the same ward, will people have the treatment and the prevention activities for malaria, as well as concentrating on managing the COVID infection? So we also don't know what the role of glucose is, giving glucose, and we know that some people have said that anticoagulants have helped in the treatment of COVID. That might not be a good idea in malaria patients. And we know that there are experimental drugs that are being used for COVID, and we don't know what the drug interactions will be with malaria and COVID. So we see that there are quite a lot of problems with the referral and management at the health facility level. The distinctive difference is that if it's just malaria, we don't need to isolate the patient. We do need to do triage to pick out the severe cases and treat them very rapidly. We don't know whether, if a patient arrives at the hospital with severe fever and possibly a cough, whether we need to completely isolate them immediately to prove whether they have malaria and COVID or malaria on its own. And if we isolate it, or we put a malaria patient in with a group of COVID patients, then there'll be cross-infection. So all of those things need to be worked out, how you manage the patients who come into the hospital. when the short supplies of PPE should be used. So I think all of those things need to be looked at from the point of view of how we manage patients when they come into the hospital with fever and possibly COVID infection. Okay. James? Okay. From the diagnosis point of view, we've got clear diagnostic tools for malaria diagnosis. But for COVID, we know that the reverse transcriptase PCRs are the gold standard test for COVID, but their sensitivity at different stages of the disease may vary according to China data. And sometimes you need to do the test more than once to prove the positivity. There are rapid point of care molecular tests which are being developed and which the FDA in America is quickly rushing onto the diagnostic places, but unfortunately the specificity and sensitivity of those tests has not actually been fully developed. So relying on those tests, what the FDA is saying is, oh, you know, clinicians use your judgment as to whether you think the test is good or not. And I don't really think that's very useful, actually, myself. We can use LAMP, and there are a series of serology tests that are being developed for COVID, which would show the antibodies being developed during the course of an infection. The problem is we don't know when the antibodies are produced. We know that more severe cases tend to produce the antibodies early. People with mild cases might not develop them for several weeks. We don't know the sensitivity and specificity of those tests. So using them for surveillance will be quite challenging. We know that it's a good idea, but for malaria serology as well, serology has been used, but again, it's very difficult to know when they become positive, how long they stay positive, etc. So serology is still a bit of a challenge for us at the moment. Okay, James? James? Okay. We're looking at the therapies that are available. For malaria, we've got some good therapies. We've got ACTs, we've got injectable artesunate, we've got gametocytocidal drugs like primaquine, we've got hypnocytocidals like primaquine and tefenaquine. But in COVID, we haven't got any proven treatments as yet. Multiple testing is going on. WHO has a 5-center testing lots of different approaches. The most effective at the moment appears to be remdesivir, which is a nucleotide analog. Chloroquine has been said to be fairly effective. There's protease inhibitors, which are the HIV drugs. Statins, which are used, which affect ACE2 inhibitors and ACE2 cells, and other ACE2 inhibitors have also been said, if the patient is taking them to begin with for heart problems, it seems to help. We also know that there's a lot of studies going on about giving serum from recovered patients to see if that can boost the immune response of the person, the anti-inflammatory immune response rather than the pro-inflammatory immune response. We know for malaria, we've got lots of chemoprevention interventions, whereas for COVID, there aren't anyone at the moment. We know that the non-drug therapies, the supportive care therapies, are similar for both. And then we've got the non-pharmaceutical prevention activities. For COVID, the only thing there is making sure that people wear PPE, that they practice social distancing and self-isolation for suspected cases. That could be really difficult in our context in Africa, where people might find it extremely difficult to practice self-isolation. So there could be a lot of difference in between the low-income country settings. So we need to collect data on the epidemiology of it. So they could be affected by the high levels of malnutrition and vitamin and mineral deficiencies, which lead to a poor immune status. We know that a large number of children and even other people will not only have non-communicable diseases, but will have underlying conditions which are infectious diseases, which could be malaria, bacterial and viral pneumonias, TB and HIV. And in Asia and in some African countries now, dengue is another big viral disease which can cause similar symptoms and signs as well. So we know there's high levels of inflammation due to this infectious disease. How that will affect the progress of the disease, we don't know. We know there's high levels of underlying anemia, which can contribute to the risk of acute respiratory distress and tissue hypoxia. Immunization, we don't know what the effect of immunization has on the general immune response in children, but in Africa we know there's a low immunization uptake. We don't know the role of helminth infections will be in damping down pro-inflammatory responses. We know that there's overcrowding, making social distancing impossible, and this might result in the acquisition of herd immunity more quickly than in countries where people are more able to socially isolate. We know there's less chronic diseases and a younger population. And if it's true that young people are not as much affected as older people, then I mean there'll be less mortality in countries with younger populations. But we know there's going to be decreased access for testing and care for pneumonia, for malaria and other infectious diseases. We also know lots of other questions we don't know. Why are children not so severely infected? How will pregnant women be affected? We know that at the moment, pregnant women appear not to be more vulnerable than any other adult, but because the outbreak of COVID has been short at the moment, we don't know what effect it's going to have on women in the first trimester on their fetuses. We haven't really had clear information about how to conduct ANC and encourage delivery in hospitals. Where hospitals are overloaded with COVID cases, is this putting pregnant women about to deliver at risk to have them deliver in the hospital? We also don't know why there's a big risk difference between men and women. It seems in many countries it's about 70-30 distribution between men and women. Okay, that's my
Thank you very much, Prudence. And I'll move on quickly to the effects of the pandemic or responses to the pandemic on health systems in the context of malaria control and elimination. And what you will see here is the health system building blocks on the left side of the table, and then some supply side issues related to the delivery of those particular elements of the health system, as well as the demand side, which includes health service use, as well as actions that come from the communities. And so with regard to the health workforce, the supply side issues include the availability of PPE, the personal protective equipment, the fact that the health system utilization as a result of the large numbers of cases could create work overload, task shifting, movement restrictions could impact on the health workforce, as well as closures of health facilities as a result of either stockouts or as a result of fears, the fear of infection, and the fact that training and supervision activities will be fairly limited. It's unclear what the mental and psychosocial support needs of these health workers will be given the epidemic. We have already seen in some countries where health workers have asked for their salaries and have not been paid and have gone on strike. There's limited telemedicine capabilities in Africa and in Asia as well. The impact on users could be things like the fear of being infected by health workers. There's still confidence in the health workforce in both the public and the private sector, and hopefully that should continue going forward. But if anything does change that, that will also create some access barriers. In terms of information, routine reporting is still going on, but the chances of that being interrupted are very high, especially when they're based and there's transmission of that information using paper-based, or the need to physically move paper from one location to another. Having clarity on what the case definitions of COVID-19 cases are, such that that information can be captured. At some point, there might be a switch to syndromic surveillance, which then will have an impact on how that gets, I would say, captured within the health information system. and the fact that reliable information is needed for micro and macro planning and understanding people's risk perceptions. We all know there's an infodemic out there, and people are accessing information very rapidly using all kinds of sources, including social media. And where are those reliable sources of information that health service users can access to know what's going on, where they need to go to, and whether they are subject to restrictions despite being ill? And we know that rumors have already been spread in several countries, and how those are then impacting on service utilization and then risk perceptions as well. Transportation, I think during the Ebola outbreak in West Africa, we did see situations where commodities were in warehouses, but were not moved to service delivery points. How is that going to play in this pandemic? So stockouts should be envisaged of malaria commodities, as well as some of the other basic health needs. Will there be reprioritization of commodity needs for some of the actions in terms of responding to the pandemic, as well as reallocation of resources? The off-label use of some medicines, that is something which is likely to happen, both in terms of healthcare workers using some antimalarials, as my colleague has outlined, but also demand from health service users for those commodities to be used. We know already the impact chloroquine has had. So there will be erratic demand, use of technologies like bed nets, and how can that work in a physical distancing paradigm if a pregnant woman is feeling ill and she's the one who has been sleeping under the net with a child. What do you do? Does she sleep outside the net, or does she give the child to use the net? Then with regard to financing, as a result of reduced government expenditure, we are anticipating reallocation of resources and reprioritization in favor of COVID responses. How is that going to impact on malaria control? The price increases of commodities, but also healthcare is increasing out-of-pocket expenditure. And we know that some households have already lost incomes because of people losing their jobs, or not being able to go to, to sell produce or to earn a living. I anticipate, obviously, many of the policies to repress transmission will divert attention of leadership and governance structures. The technical guidance that's being outputted from national malaria control programs, from COVID task forces, how do those define delivery of malaria services as a core service, and how does it ensure that the delivery platforms that are responding to COVID-19 still remain viable for the delivery of malaria control services? Community engagement is vital, especially if these suppressive measures are in place for very long. How do you continue to engage communities in participating in the COVID response, but also continue to participate in the malaria control and elimination response? And the fact that if this continues for long, how is community fatigue going to affect service delivery? And we know that service delivery in much of Africa and Asia is in the public and the private sectors. The fact that PPE will need to be available, will have to be used, hand washing facilities need to be provided, the workspace for health workers to practice social distancing, and the triage that Prudence has mentioned, and the fact that some of these services will be interrupted or be opened, and how is that information relayed reliably to health service users? Will outpatients be deprioritized in favor of inpatients? What will happen to outreaches, campaigns such as long-lasting net distribution, seasonal malaria chemoprevention, as well as indoor residual spraying? The overlapping symptomatology will have a bearing on how people seek care, especially with movement restrictions, the cost of care. We have already started to see some stigmatization taking place, which could mean that fever cases remain at home. What are the myths and the fears that communities will have with regard to COVID, and the impact of switching from confirmatory diagnosis to presumptive diagnosis, and how would that affect the whole care seeking in the public as well as the private sector. Thank you. I will now hand over to Jane.
Thank you, James. So just as a reminder, we know that currently many of the malaria endemic countries are at different transmission scenarios for COVID. So we have a few countries that still haven't reported any cases. Some have reported sporadic cases, and a number with clusters of cases, and a few others that have had significant community transmission ongoing. And the research priorities really are governed or guided by the different transmission settings and scenarios for COVID that these countries have. And we know that to date, there's been very limited data coming out of Africa for any aspects of the COVID pandemic. So in terms of just the surveillance, I think there are key questions that need to be addressed, not just related to malaria, but just understanding the profile of the COVID cases that are being seen in the malaria endemic settings. For example, what is the age pattern of COVID-19 disease that we see across these different malaria transmission settings? We know that in some of the other settings, it has been shown that children may not be significantly at risk, but are we going to see similar patterns in these different malaria endemic settings? Also, what are the clinical features of mild, moderate, and severe COVID disease in these malaria endemic countries? Will there also be some seasonality or seasonal variations in the incidence of COVID in malaria endemic settings, like we see for some of the seasonal malaria transmission settings? And also, does co-infection with COVID-19 virus and Plasmodium falciparum or Plasmodium vivax have an influence on both the presentation, but also the clinical outcomes and the prognosis of illness in these different transmission settings? Next slide. Of course, one key question that cuts across all these settings is also the clinical management aspects of the pandemic, but also of the two diseases. How are patients who are presenting with fever in malaria endemic settings to be managed? We've heard about the close proximity that is needed in assessing patients coming in with fever, and at the community level, how are these people to be managed, especially with the stigma of exposure and all that? What is the role of anemia in the severity of malaria and in the context of COVID-19 co-infection? In these patients that may come in with co-infection with COVID-19 and either falciparum or vivax malaria, what would be the optimal treatment modalities that should be used in these patients? And of course, what is the role of the commonly used drugs, the antimethicillin-based combination therapies and antibiotics that are sometimes given in the setting of community-based approaches for the clinical course of COVID infections in children that they may see specifically? A few other clinical management questions or key research ideas that may come up is, how should the case management algorithm change at different levels of malaria and COVID disease to optimize health outcomes? If you have a highly prevalent malaria setting with still either no cases or the lower transmission levels of COVID, how should the case management algorithms adjust to optimize health outcomes in these settings? And of course, in settings where there is co-infection with malaria and COVID, what is the role of blood transfusion in managing anemia and septic shock? We've seen a lot of hypoxemia in the setting of COVID. How would transmission from malaria, for example, impact on the outcomes in those patients? And then largely a lot of concerns, especially in the African setting, for the national health infrastructure. If these are overwhelmed by the pandemic of COVID, how would their function in the managing of the other common mobilities occur? What are those kind of bottlenecks and shortcomings that need to be addressed to ensure that other existing health programs remain viable, functional, even in light of the COVID epidemic? Of course, in settings where the health systems may be overwhelmed by the number of COVID cases, they may be need to implement and evaluate some mass drug administration approaches. And how would those have an impact on malaria and COVID in the settings where these efforts should be carefully evaluated? So essentially, what role would mass drug administration play in these kind of scenarios? In terms of the epidemiology, just to kind of enhance our understanding of how COVID would behave in malaria endemic settings, because both diseases present with fever and there is significant symptom overlap, what would the malaria programs use as early warning signs of a malaria outbreak? Because a lot of activities targeting COVID, a lot of the screening for fevers will be within the COVID programs. What are the signs that would show that there may be an outbreak of malaria in some of these settings? And then also, does infection with COVID, malaria, or dengue reduce immune protection against any of these infections by any of the others? So what are the immunological interactions between these different comorbidities in these settings? And then, of course, will there be need to develop fever algorithms or symptom checkers to enhance the screening for COVID at the community level? Right now, the community structures are geared towards malaria screening or the screening for other conditions like pneumonia. Would there be a need to enhance these to also incorporate screening for COVID in the setting that this is the platform that is available at the community level? Of course, we've talked largely about immunization status, but how would that have an impact on severity? Interesting, of course, a lot of evidence from BCG and BCG being protective, but also the other vaccines that are shown to enhance the T-cell immunity like measles, hepatitis B, and influenza. How will those impact the severity of COVID, especially in these settings with different immunization coverage? Also interest in helminth infections that have been shown to mediate adverse inflammatory responses. What would the association be between COVID and helminths that are also co-prevalent in these several malaria endemic settings that we are concerned about? A lot of interest and focus in infection prevention and control, especially for healthcare workers, even at the community level. It would be important to understand the level of knowledge for these frontline healthcare workers for infection control at the levels where they work, within the communities. What is their understanding of infection prevention and control? What would be considered minimum PPE requirements for the community health workers, for example, in this setting of COVID? Is a mask enough? Do they need more than a mask in these settings? And also, if they are to be used as frontline health workers at the community level, what is their perception of risk, or what is their acceptability to continue to serve febrile patients with a minimum PPE supply that they may have in the context of COVID? Next slide. Next slide, James. Of course, there's also a lot of interest in community mobilization, but I think there's still, if the previous slide, James, please. So there's a lot of interest in understanding the most effective methods of providing information to the community about COVID, especially the need for treatment seeking for patients with fever, and then also the safe uptake of the existing preventive measures for malaria, pneumonia, and diarrhea. And then, of course, do these methodologies that exist at the community level need to change, and do they need to be adapted to the different transmission scenarios for COVID in the different countries? And what are the most effective ways to address some of these underlying issues that drive fear, anxiety, stigma? How do we essentially improve public knowledge and awareness and trust of the existing measures that are being taken during the COVID response? Next slide. And then, of course, there are lots of mental and psychosocial issues, and some of the key questions are: what are the relevant, acceptable, and feasible approaches for supporting the psychosocial needs of care providers, not just at the health facility level, but also at the community level? And how can we also utilize some of these community health workers to be able to provide some of this psychosocial support within the homes, within the community quarantine regions, or any of the isolation centers that they may have? So critical psychosocial support issues also arise. Next slide. And finally, of course, there are significant social sciences and ethical issues in the context of this outbreak. For example, there's a lot of information going on social distancing, but how do we better package the social distancing messages, especially when you look at the impact of social distancing on the utilization of some of the malaria control interventions like bed nets? Will two people be able to share one bed net? Should there be more bed nets distributed because of the the social distancing that is currently being advocated for? And then, of course, personal communication and the social network theory that is used in malaria prevention campaigns. Can this also be useful to enhance the adoption of social distancing? What are the enablers for people to adopt the social distancing advice. And critically, as we discuss the different research questions, I think the critical issue is about the ethical considerations of research in the context of an epidemic. We need to find innovative ways of ensuring that there is ethical oversight and that all the research studies that are done within the governing regulations that exist. So thank you very much for the attention.